University Oman, Senior Consultant of Medical and Biochemical Genetics. هيكلمنا النهارده عن الكلاسيك جلاكتوزيميا ستاندرد اند ثيرابي.
السلام عليكم ورحمة الله. بتقدم بالشكر الجزيل للسيادة الدكتورة سناء على الدعوة الكريمة. صرت مدعو بصفة مستمرة سنويا نفتقد هذا المكان تقريبا في نفس الوقت، وتقدم بالشكر الجزيل موصول للبروفيسور علي for the arrangement. This is the task that was given for me to talk about, and that is classic galactosemia, standard and evolving therapy. And what I'll do through this presentation, hopefully, would be to give a brief historical background eventually, and then we'll talk about biochemical pathway, the Lilleware pathway, which is involved in classic galactosemia, and then we'll one slide on clinical manifestation historically before the era of newborn screening. I'll highlight aspects related to current management guidelines, and then shed light on the unmet needs in classic galactosemia management, and what is happening in the area of developing therapeutics in this field. So our knowledge when it comes to classic galactosemia has gone through important key historical milestones. The first one has been the description of galactosemia that was described by in the early 1900s by von Ross, and then subsequently, way before the GALT enzyme was characterized, a 10-month-old infant affected with the galactosemia was actually treated successfully with a lactose-restricted diet in 1935. The GALT enzyme activity was defined only 20 years later, and the next important milestone has been the actual delineation of the Lilleware pathway, for which Louis Lilleware received the Nobel Prize in Chemistry in 1970. And I think the next important clinical milestone when it comes to management of these patients with this disease has been the establishment of the International Network for Galactosemia, or GALNet, which has contributed significantly to delineating the natural history of the disease in these patients. I know it may not be the best idea to talk about biochemical pathways on a Friday morning towards the end of the session, but it's unavoidable that I actually sort of give you an important highlight of the important steps involved in this pathway. So the galactose that we actually receive in the diet is liberated from lactose through the action of lactase. The galactose that is released from lactase is actually in the conformational form of the beta conformation, and that's not the form that it should be enter into the Lilleware pathway. It needs to be converted into the alpha form, alpha conformation of galactose, and that's the function of galactose aminotransferase. Then subsequently, the alpha D-galactose gets phosphorylated by the action of galactose kinase, and then eventually gets converted into galactose 1-phosphate through the galactose 1-phosphate uridyl transferase. Now, the enzyme, the Lilleware pathway is only from the alpha D galactose into the galactose 1-phosphate production. The GALT enzyme activity, that biochemical reaction, is also coupled with the conversion of UDP glucose into UDP galactose through a galactose 4' epimerase. And both of these products, the UDP galactose and glucose 1-phosphate, are important. Glucose 1-phosphate enters into the glycolytic and gluconeogenesis pathway, and the UDP galactose is important as a donor of galactose for our glycosylation reactions. Both of them have impact on these biochemical pathways if the pathway is impaired. The alpha D galactose is also metabolized through two accessory pathways. The aldose reductase converts alpha D galactose into galactitol, and the galactitol becomes concentrated, it deposits, it doesn't really it's not well soluble, and it also causes significant osmotic effect. Cells swell up in the lens particularly, and that contributes to development of cataract. Alpha D galactose can also be converted to galactonase through the galactose dehydrogenase enzyme. So these are the main important enzymes that I wanted to highlight in this slide. Moving into the clinical aspect related to galactosemia, we don't see this anymore. Infants untreated usually present with acute hepatocellular dysfunction of various components denoting liver failure. They develop vomiting, feeding intolerance. There are significant risk of sepsis, particularly with E. coli. They would fail to thrive, and some of them may actually develop seizures. If a patient missed being diagnosed early on, then they come on as later on as a growing child, then we see developmental delays, speech abnormalities, abnormalities of motor function, including ataxia, extrapyramidal movements. They develop cataract as a complication. Of course, they may be at risk of liver cirrhosis with a progressive liver disease. And females are at risk of premature ovarian failure or primary ovarian infertility. There are two important variants to remember with galactosemia. The reason why I mention them is because they may come in the context of newborn screening. They are associated with reduced enzyme activity. The Duarte variant would have 50% reduction, 50% of that enzyme activity with the control. They usually are compound heterozygous for a variant in association with a deletion in the promoter region. Later on, the Los Angeles variant was described. Essentially, these individuals have a single nucleotide change that converts asparagine into aspartate in conjunction with a 4-base pair deletion in the promoter region. It's actually the deletion that contributes to reduction in enzyme activity. This is usually in linkage disequilibrium with these variants in the Duarte variant, and only with this variant in the Los Angeles variant. The reason why I mention them is because they may come across, you may come across them with reduced enzyme activity, because the N314D is relatively common in the globe with a frequency of about 8 to 15%. So the current international guidelines when it comes to management focuses on immediate removal of galactose to a galactose-restricted diet. That's basically formula supplementation devoid of galactose, and it's a lifelong therapy. And the current management guideline emphasizes that we only need to eliminate sources of lactose and galactose from dairy products, but permit galactose from non-milk sources. There is not enough evidence to suggest treating versus not treating patients with reduced enzyme activity that is more than 10%. And of course, it's left to clinical judgment. And there are many monitoring guidelines that are described and you can refer to in the guidelines. So how strict we need to be when it comes to galactose restriction? I think it's important to remember a few important facts. Some galactose is inevitably introduced in the diet, so you can't really avoid. The lactose-free diet that is highly enriched in fruits and vegetables resulted in a mean galactose intake of about 50 milligram per day. Galactose supplementation was demonstrated that actually if it was liberalized to a level of a total of 600 milligram per day, did not really result in significant clinical sequelae. And there is no difference when it comes to long-term management in 14 families where a total of 30 subjects were followed. Some with levels less than 20 milligram per day and others with levels more than 20 milligram per day. There was no difference when it comes to clinical outcomes. And galactosemic patients endogenously synthesize their galactose to an extent that actually exceeds that they get from non-dairy products. In fact, an adult patient may actually synthesize endogenously a total of 1,000 milligram per day. So that ultimately led to this statement within the guideline that long-term, lifelong galactose-restricted diet that only eliminates sources of lactose and galactose from dairy products while allowing mature cheese, caseinate, and non-milk food. So there's a diversity of management that has been demonstrated across different studies. This survey was actually distributed globally. 13 survey responses were received from 11 countries. There was clear differences in terms of how strict treating physicians are when it comes to management of patients with galactosemia. And the negative outcomes did not seem to be impacted by how strict you are and by the type of intervention or frequency of follow-up that was adapted in these countries. So bottom line, there is currently no one best practice for treating patients with classic galactosemia. Thanks to the natural history that is depicted and showed by the GalNet registry, we know now, of course, that these patients still, despite being diagnosed early, oligosymptomatically or presymptomatically treated with an appropriately acceptable galactose-restricted diet, these patients still develop significant complications. Developmental delay is seen in a significant number of patients. There are neurological complications, including motor abnormalities, ataxia, seizures, that is seen in patients with classic galactosemia treated early. And we also know that language impairment, speech dyspraxia is a significant problem that is encountered in a significant number of patients. And of course, the big challenge when it comes to premature ovarian insufficiency that is seen in patients, in female patients with classic galactosemia, that could not be prevented, of course, by the current available therapy. It's not entirely known as to why primary ovarian insufficiency happens in females. There are proposed pathomechanisms that include an ovarian damage that is caused by elevation of galactose 1-phosphate and galactitol. There is the question of whether you, in fact, you have less available UDP galactose. That means that it would impede glycosylation of glycoconjugates, which are a requirement for normal follicle development. There is also the hypothesis of increased apoptosis of maturing follicles with accelerated follicular atresia. And there has been a hypothesis of unrecognized auto-ovarian antibodies that is seen in patients with classic galactosemia. So clearly speaking, we need alternative therapies because we do have unmet needs when it comes to management of classic galactosemia. Some of the complications continue to exist despite early treatment. And among the various ways you can approach this aspect in terms of shortcomings would be gene therapy, in which there are actually trials and along the left, there are actually preclinical trials now in animal models. There is the mRNA-based therapy, which seems to be promising. The galactosemia is a conformational disorder, and that's why it is proposed that it should be available to molecular chaperone therapy. There are ways of targeting those accessory pathways. So there is the option of inhibiting aldose reductase with reduction in the production of galactitol. That's govorestat, which I'll be talking about in the next slide. There is another way that may be considered, which is inhibiting galactokinase 1, so that you actually do not produce galactose 1-phosphate, and then you couple that with the galactose restriction. And of course, there is the question of dealing with endoplasmic reticulum stress that has been demonstrated to be part of the pathogenesis in patients with classic galactosemia. And there is the symptomatic treatment, cryopreservation, and oocyte donor, depending on where you come from when it comes to management of primary ovarian infertility. I've visited the clinicaltrials.org. I'm not going to show you all of this, and I'll focus only on 3 recent patents that were actually filed. One of them is linked to this phase 1-2 clinical trial, and that is treatment of with govorestat, which is basically an aldose reductase inhibitor. This is a pharmacokinetic, pharmacodynamic study that evaluated single and multiple doses escalated when it comes to the dose of govorestat, compared healthy adults and classic galactosemic patients. And you can see that actually the drug has resulted in significant reduction in total galactose. And the dose of 20 milligram per kilo was not different than the 40 milligram per kilo. When you inhibit aldose reductase, you fear that, unfortunately that's not work, you fear that you could lead to elevation of galactose and galactose 1-phosphate because of that inhibition. But then this was not demonstrated to be the case at the therapeutic doses that were used in the treatment of these patients. The next one is, of course, galactosemia, being as an inborn metabolism, single enzyme defect, is also amenable to consideration of therapy with mRNA, and in fact, this was a demonstration of the proof of concept. mRNA therapy with GALT protein was expressed in zebrafish when delivered as naked mRNA and as an encapsulated mRNA with liquid nanoparticle. And then there has been a trend towards reduction in galactose 1-phosphate and galactonate when they are in zebrafish exposed to galactose compared to, but of course the level of reduction was not as you see with the wild type. So mRNA would be something that is to be considered. It is in development, and hopefully we'll see it in a clinical trial soon. This is the slide before the conclusion slide. One component that is related to pathogenesis in patients with classic galactosemia is the damage of endoplasmic reticulum. It has been shown that, in fact, the pathway associated that demarks endoplasmic reticulum stress is downregulated. That is the protein kinase. The protein kinase pathway is downregulated, and if you treat this with agents that would actually salvage and improve the protein kinase reaction and readjust the protein kinase, you could actually abolish and decrease the endoplasmic reticulum stress that is associated with the disease. This was actually demonstrated by treatment with celebrinal, which is basically an eukaryotic initiation factor 2 alpha specific inhibitor, which has led to a reduction of an adjustment and modification of the endoplasmic reticulum stress-related pathway. And in fact, indeed, this did lead to salvaging Purkinje fibers from being lost, and also improved the surviving follicles in the ovaries. This is my concluding slide. Essentially, we are dealing with a disease with complex underlying pathogenic mechanism, and although neonatal screening contributed significantly to mitigating the acute hepatic damage phenotype, despite the newborn screening, we continue to see long-term complication. We've seen that govorestat, an aldose reductase inhibitor, may actually hold promise for mitigating the phenotype in patients with classic galactosemia, and there are other therapies in development. Thank you for listening.
Thank you, Professor Khaled, for your great lecture. I just have one question. Do you have a lot of patients for galactosemia?
Yeah, we don't have newborn screening in Oman for galactosemia at present. This is going to change hopefully in the next few months. But we have a total of close to 40 patients with classic galactosemia.
And what is the most common important errors of metabolism at your hospital? What will
Maple
be?
syrup urine disease.
Yeah, exactly like ours and like King Faisal also.
Thank you دكتور خالد. وإن شاء الله نشوفك كل سنة معنا في المؤتمر.